Good morning. It's just really a pleasure to be here at this conference. And really, I think that this, for me at least, and I don't know how you'll feel, but for me at least, this is a very unique group of individuals who've come together to talk about something that is not talked about a lot. So I'm very thankful, Doug, and to the conference organizers and to the sponsors for allowing me to be here amongst you all today. So for those who are here for the Pediatrics Palliative Care Conference, I'm going to take the concepts that I talked about there, kind of make them practical in the case that I present this morning. So, and you'll hear some of the slides look the same because they are the same. But in any case, I think I lead a program that is at the intersection of religion and medicine. And for many of us, when we think about religion and healthcare, we come in with preconceived notions around the debate between religion and science, right? Where we think that, religion or science is about empiricism and religion is about superstition. Where science is about rationality and religion is about belief. And where science is about universal ideas, right, things that we can all agree upon, but religion is very particular. And so this kind of colors the debate that we have both within the public sphere and the public domain, as well as in our professional circles. I would argue, and I tried to show that a little bit a few days ago, that this dividing line isn't as clear as we think it is, right? That the fact is that religion, when you think about religious texts, that they're hermeneutical theories that are based upon rationality to understand what they mean and how we sort of take them and that understanding forward. That science is also about belief. Beliefs about what we can know or how far our investigations can yield truth. That there is a belief embedded within scientific endeavors as well. And then I also think that's very interesting that in these debates that the Muslims oftentimes are aloof to them, right? They're outside of, because in our tradition, in our history, there wasn't this notion of religion versus revelation, right? We didn't have a church system that was trying to hide sort of scientific findings, so that carryover, that spillover, doesn't occur as much within the Muslim tradition. At the same time, I know that for a lot of people here, and ethics councils particularly, you get invited to conversations where people are towing the line, particularly around faith healing, and miracles, and these beliefs, where we are often called to try to think about where the boundary positions are between, again, religious systems and what we think is conventions of healthcare. So with that backdrop, I'll say that I think there are convergences between religion and medicine, as well as divergences. And the convergences are that they both respond to human queries and needs, right? They both speak to what we are, why things happen to us, and what will be our end. They speak to this. At the same time, we have to recognize, particularly in the ethics realm, that they differ in their frameworks of epistemology, of moral reasoning, as well as in ontology, what we are, how we are, what the reality of two things is. But when you are an ethics consultant, I think it's very important for us to go into that room, to go into that conversation thinking about the fact that medicine is a cultural system, that it involves certain authority structures with a certain specialized vocabulary, right, that can have a moral tinge to it. So the fact that we say doctor's orders means something. When we call patients non-adherent or non-compliant, it means something. There is a moral undergrounding to that language and the way that we deploy it. And I want us to be cognizant of that. At the same time, medicine has some texts that some of us think have moral truths within them, right? That a great many of the people who practice medicine and healthcare would adhere to and derive moral frameworks from. And at the same time, medicine does have an ontological schema, right? It does have a belief system that certain things that we see or may not see yield certain sorts of symptoms in people that we can understand or may not understand, and that will produce certain ends, right? That will produce certain ends for that patient and that family. So with that said, let's sort of launch into this case that is about Fatima and Ali and their son Ahmed. So Fatima and Ali are a Yemeni refugee family living in Michigan, and they have a son, Ahmed, who's about 3 years old, who has trisomy 21. And as with many children who have trisomy 21, he has an arterioventricular septal defect that when he was younger, they tried to repair, but it was unsuccessful. So over the course of the last year and a half, he's had progressive heart failure. He was admitted recently to the PICU for a pneumonia, and he has persistent hypoxia throughout his stay. He's been in the hospital for about 3 weeks, and he remains ventilator dependent with fluid overload that's worsening, obviously leading to worsening pulmonary status. So the first challenge in the course of this care was around goals of care conversations, right? Where the parents who've been at the bedside the entire time, they voice a preference for continued maximal support and invasive interventions. Repeated attempts by the treating team to sort of talk about palliative care or to offer a palliative care consult, involve spiritual care individuals in the hospital have been rebuffed mostly by the father. And the treating clinicians and the team, both nurses and the trainees, are worried about the harms and risks associated with this continued ventilator support, a story that you all know, right? And they talk about this concept, which is ill-defined, about futility. Right? So in this context, and they forecast where this is going, so they call ahead and they ask for an ethics consultation with the following questions. First, to what extent can clinicians deviate from parental wishes, all right, in this care, but more generally? And when would it be appropriate for the hospital to consider the hospital to go to court, as we talked about yesterday, to take guardian status from the parents, or invoke some notion of conscience? All right, the medical students and the trainees have been reading a lot about these things, so they talk about conscience due to clinical moral distress. Then lastly, they ask, how should the team react to decision-making dominance, is the word that they use, from the father? So as any ethics consultant would do, the ethics consultant thinks about, well, what is underlying all of this, right? There might be many things going on. So before he or she enters the conversation, they think about, well, is this maybe just denial, right? That the parents are in denial of what is actually happening. Maybe there's some poor coping with reality. Perhaps the family, right, they are refugees from Yemen. They have a lack of health literacy, that they can't actually see what's happening. They might not understand what their options are or are not. Perhaps they don't trust the healthcare system, right? And they're worried about biased care or discriminatory care. And then perhaps in their community, in their religious system, in their society where they came from, there are patriarchal cultural norms that lead to this dominance that this team is seeing from the father in decision making. So they have a conversation, not a very high stakes one. In that conversation, the ethics consultant finds several things. First, the father perceived himself to be morally liable for decision making, and the mother defers to this. She agrees to this, and she recognizes the same. They understand themselves, the parents together, to be obligated to pursue everything in their power to preserve the child's life. Right? This is their duty as parents. That is actually the way they think about the moral status of being parents. That's the definition for them. And then they perceive the clinicians, right, who come in and out, right, spend less and less time every day, right, to be very busy. Right? And they're so busy that they're ready to give up on their child. So the consultant thinks about these values, and then they find a Muslim physician in the hospital, and they say, well, what is underlying this? Are there actually religious tenets here? Right? This question about religion and culture always comes up. So they talk to a physician, the consultants talk to a physician, and they think about these, the consultant offers these things, right? For example, that within that faith, there is a prophetic tradition about hope and trust related to this context about visiting the sick. And he says, the prophet had said, when you visit a sick person, speak in a reassuring way to him, saying that this will not delay, the prophet said, what is predestined, but it will certainly make him feel happy. So this is how they enter the conversation about visiting the sick or their sick families. And there are verses in the Quran that speak about not giving up hope in God, right? As the two I've quoted here. So that's what the physician and the staff tells them. He also talks about this concept of custodianship or guardianship, which is called wilaya in Arabic, right? That it leads to moral culpability for people. So there's a narration again from the Prophet that each of you is a shepherd and will be asked about those under your guardianship. And this continues on to different categories of individuals, starting with actually, the father, right? That the father is responsible for the wife and children, the mother is responsible for those within the household, these sorts of things. That there is an order of scope here between who's ultimately responsible to God, right, for the custodianship of those under their care. And that this relates to fiscal, intellectual, social, spiritual, and health. All of these are in this domain. So on the day of judgment, they'll be asked about this. So the ethics consultant then says, okay, well, let me answer those three questions that were posed, and this is how the ethics consultant responds. About the issue about being constrained by parental wishes, when it would be appropriate to go to court to take over, to take guardianship of the child, or for them to claim conscience and not proceed to do the things that the family wants them to do. That yes, certainly the clinical team could pursue unilateral DNR or guardianship, but the threshold's high. He actually read Deekema's paper and said, oh, these 8 criteria aren't present. The parents are acting out of a caring ethos for the child, and that the clinical situation is not of imminent harm. The consultant also notes that the harms of such action might lead to misperceptions in the community. Again, this is a Yemeni refugee community, and these parents are part of that community. So if anything happens here, it's not just to this, right, this circle, but another circle beyond the hospital doors. And then that they can ask the parents if future decisions can involve religious leaders, and that's the one recommendation, that we should try to bring in religious leaders, not from the hospital, not chaplains and staff here, but someone outside. Perhaps they can come and participate in those discussions where they happen down the road. And about this issue about how should the team react to the dominance of the father in decision-making, the consultant says, well, this seems to be ethically justified based on religious norms. Really, there is no harm here to rectify. The mother seems to be accepting of this rubric. Okay, so the second challenge that comes about in the care for this child is that during the weekend, on the weekend overnight shift, right, when Ahmed suffers a hypoxic arrest, right, we know there's no DNR on file, and the treating team, in this case the senior residents, perform an interesting procedure called a slow code, right, believing that it is justified and a negotiated solution to the moral distress of the staff. So Ahmed ends up surviving this slow code, survives the night, and the next morning the PICU fellow comes in and finds that on the rounds that Ahmed doesn't really have brainstem reflexes and has no respiratory drive. So you all see where this is going. The family arrives a little bit later, and the events are discussed with them, and the PICU fellow shares that the neurology team will come back and perform brain death examinations twice in the next 24 hours. Right? They weren't as savvy to say, neurological criteria for death. They just said brain death. So the parents are visibly shaken and take several actions. First, they ask the hospital for transfer, quoting precedents in the case that we heard about yesterday. They note that they would not accept brain death as death because of religious conflicts with that notion, and they contact the Yemeni embassy for assistance in this case. So the clinical care team on the hand says, they're doing all these things, let's do our own escalation. So they talk to risk management, and they call in the ethics consultant back for advice and course of action. The legal team notes that brain death is legal death in Michigan, right? That once it's determined, transfer will not be covered by any insurance. And they hold a multidisciplinary meeting, anticipating that there will be another meeting with the family and perhaps a religious leader a little later on. So they want to get their story straight and understand all the dimensions of this challenge that they forecast will occur. So social work says that no facility will accept this patient transfer at this point. Neurology says that the first brain death exam is positive. Our protocol in the hospital requires another one within 24 hours, so they intend to do that unless they're told not to. The treating team notes that throughout the day the family's been, quote unquote, barricading the room, making care of delivery difficult for the nursing staff to check on Ahmed. And an enterprising medical student on the team says, I find a paper that notes that brain death is acceptable in Islam, and so that he says, let me kind of look into that a little bit more. So as any good ethics consultant, the ethics consultant does some reading and says, okay, show me what you found, oh medical student. So the medical student looks up at some papers, and the consultant said, let me read through these. So that consultant finds that brain death has various notions within the Islamic tradition. These are three rulings I've accepted for you. That, for example, a large juridical academy in Saudi Arabia that involved both physicians and legal scholars, they declare that brain death is legal death in Islam, and they use this language. I think this language becomes very important for us to think about. They say in their fatwa that all vital functions of the brain must cease irreversibly, and the brain has started to degenerate. When this state occurs, then the withdrawal of life support is permitted. Another academy in Kuwait, again similarly composed of both physicians and jurists, they rule that brain death is unstable life, that truly it's a dying state. And they note that if a person has reached brain stem death, so they specify the type of exam that should be done, they note that some of the rulings of unstable life apply. And this category of unstable life is that liminal state between dead, right, and dying. I mean, the state of dying between death and being alive. So they also note that withdrawal of life support is permitted. Now, both of these academies have some Shi'i scholars, but they are situated by a dominance of Sunni scholars. So Shia authorities from Iran, these are two names that I've sculpted for you here, they note that brain death is not death. Right? That not only is brain death not death, and their notion is that in that state, we don't know if that being is communicating with their Lord. and any communication with their Lord can be salvific, so we should let that be. But they also further note that the people who adhere to Jafri fiqh here must not participate in the removal of life support, that they are culpable for sin if they do that, both clinicians and parents. So further reading, that enterprising consultant finds that there are different views on the moral status of seeking medical care within the tradition. Right? The dominant Sunni view is that it is a permitted act, right? That it only becomes obligated when the curative or restorative potential of treatment, that specific treatment, is certain, or dominantly certain, so that you know that you're going to give something and that's going to restore the individual to some state. And the dominant Shia view is again different, right? That there is moral obligation to the limits of one's capacity, to all ends. That any notion of life is one of ultimate sort of quote-unquote value. So the consultant then offers to have a listening meeting, right, where they and the parents and their religious leader can come and set the agenda for the meeting. He just wants to hear more. He had told them that I'd heard about these papers. I want to get a sense of what you believe and what your religious leader believes and how we should proceed in your mind. So the meeting reveals that the family is indeed Shia, right, and that their marja, their religious authority, does not consider brain death to be death. So that statement that was made several hours ago was actually one that was fact by their view. The family also believes that they're morally liable for sin should they participate in withdrawing life support. Again, following the advice of that religious leader and that view. So this is how they perceive the situation at this point. So thinking about it in the past that's going to happen, the ethics consultant is a little bit concerned, knowing, right, that another exam might be performed shortly, that no insurance company will then pay for that care. Transfer is not a possibility. And so it's very concerned that there's going to lead to some significant conflict when that occurs, because for them, it's about them participating in the sinful act. And the imam is also holding that this is true, this is a true view. So after that meeting, again, it was just a listening meeting, the imam sort of takes the doctor to the side and says, okay, let's just walk. Can you show me that scanner, right, that I hear so much about? And he notes, medicine is amazing, but miracles come from God. So that ethics consultant says, well, yeah, we could all use a miracle right now. All I see is harms, right? That Ahmed's being harmed by this care, mom and dad are suffering, in using that term, and that the clinical team here also has some notions of distress. So all I see are harms on all sides. I don't see a path forward necessarily. So the imam says, well, would you say that we are at the limits of your medical care, that shortly after the respirator is removed, Ahmed's heart would stop beating? And the consultant says, yes, I would. So the imam then says, let's give God a chance to work his miracles. If he chooses, you have to let the family live without burden. I think we might agree that the parents must endure whether or not Ahmed does. So the doctor says, what do you suggest? He says, well, let Ahmed go home so that we might pray on him. So upon advice, the ethics consultant goes back and sort of writes some recommendations, talks to the PICU team, and says, can we orchestrate this really odd request? Can we accommodate this? And can we do so with resources that the hospital will give? So they come up with this sort of solution, that the hospital will use its own transport team to bring Ahmed home on a portable vent, and a neurointensivist will accompany that team. The parents, the imam, and the mosque health committee, because many mosques have health committees that visit people who are sick, they're going to be at the house, right? So they're at the house and they help situate Ahmed in his bed, and the imam starts leading some prayer rituals. The imam then asks the neurologist to do what you would have done in the hospital, right? Knowing that there was a second exam to be done to confirm this diagnosis. So the neurologist does that, right, to the best of his ability, and suggests that, brain that quote-unquote is certified here, and that if I was in the hospital, the ventilator would be discontinued. And the ventilator is the hospital's property here, right? So he says, do what you would have done there. We want the same sort of care. So the imam prays for God's mercy, and then Ahmed passes away. So the point of this sort of, for us, and I said that this is a slide I shared a few days ago, was that as we engage in consultations around categories of culture or religion and how medicine interacts with them, that we must seek to discover the meanings and values for certain types of interventions and for the states that we are in from both the clinical perspective as well as from the religious or the cultural value system that the patients and family bring with them. That we must consider the norms and constraints upon our own behaviors, but also upon theirs. As in this case, as you saw, should they have participated in saying, yeah, you can take off, you can withdraw life support, they would be morally culpable for sin, according to their tradition. And so we have to understand the constraints and norms that they bring to that encounter. And also, as was remarked yesterday, this notion of the male dominance perhaps in medical decision-making. And that when we then proceed to negotiate or try to accommodate different value systems, that there are meanings to both actions and non-actions, right? The non-action of not asking the family to do anything. The family you saw was removed from the conversation after the imam came in, right? This is a non-action. No one pursued them. Do you agree with this? Right? They were deferring to the authority of the imam in this case. Some might say that's objectionable, but sometimes you have to think about the significance of both the non-action and the action. What are you putting and what are you imposing upon those individuals? So, I think we have to come to these as ethics consultants with a notion of cultural openness and humility, that our moral system is not superior to another person's moral system necessarily, and there are lines where we might say that there's something wrong here, but we shouldn't come in with that. Right? We shouldn't come in with that. And that we should be tolerating of inconvenience. Right? Families and parents and patients are inconvenienced by the fact that they are sick and they have to come to see us. Right? Oftentimes we are not on the same sort of ethic of reciprocity, that I'm willing to be a little bit inconvenienced, right? To try to accommodate your system. And I'm not saying do that all the time, but we have to come in again with this when we enter that conversation, that there might be some inconveniences, that a burden that I have to bear as I try to do best by the patient, by the family, and actually by the healthcare system as well. So my practical advice for all of us is that, we often, and particularly I work in the emergency department, this often comes up, that we think ourselves as resource poor, right? And that leads at times to us making hasty decisions. The resource that we need here is patience, right? And to reason and think through things. That's not a question necessarily about money. It's about our attitudes and what we are emotionally willing to invest in that conversation. So I encourage you to do that, to invest yourselves fully. That resource we can give. And hopefully in your environments, that well is strong. That you're supported to have a really deep well of emotional reserve to enter these conversations. Take the time to gather family, to get ethics and religious support should it be needed. Recognize that language and framing matters. In our conversations. I gave you this notion of doctor's orders and noncompliance, but all the language that we use is morally laden in the healthcare environment. And for those who speak multiple languages, you can tell that. Many of us don't, but really, and the way that you translate those concepts, again, can either correctly or incorrectly translate that moral significance of the language that we use. So I ask you all and myself to develop understanding regarding the concepts of import to the communities that we serve. There are many of them. And I'm not saying that you generalize, but you should know something when you enter that encounter. That there are multiple layers of ethical, moral responsibility, culpability, right? So there are things that we will do at the patient-doctor level that we wouldn't do at the community healthcare system level. There are things that we wouldn't do at the legal level or the policy level. That we must understand that everything that we do has this sort of extrapolation out, but also has relevance into that one-on-one conversation with that parent or that family member. So think about that. Both the professional ethics issues that come up, but also, can I bend the professional ethics to take care of this just one person in front of me right now? That's whose lives is important. Err towards deferring to the family and to let specialists engage in conversations. Yesterday you heard about this notion of cultural brokers, about individuals within the team or people that we can hire that have some specialized expertise in these sorts of issues. We should let them, help us understand what's going on. Don't be the person who is remembered by the family or that community as the one who didn't listen, who didn't take that time, or they forced us to do something, or discriminated against us. All right, that these sorts of things have ramifications, and I have data, at least from the Muslim community, that they have ramifications for future healthcare seeking decisions beyond that particular family. So just be cognizant of that as you enter that conversation. So with that, I will end, and I'm looking forward to our panel conversation later on. Thank you.